people because it is, I don't know, starting from 3 to most probably 10. So back to back, so many questions will be discussed. So be prepared. So the first thing is we'll start with poisoning, okay? Hope you people are able to see my screen.
Yes, ma'am, it's visible.
Okay, okay. Thank you. So, so first topic for today's crash course is poisoning. So I'll be discussing about three important topics. One is the basic thing, okay, how to approach unknown poison in a way of toxidromic approach, okay, and the second would be paracetamol poisoning, and third would be the extracorporeal removal of the toxins, okay. So first would be your toxidromic approach, okay. So what is toxidrome? Basically, this toxidrome is a combination of two important words. One is toxic, second is syndromes. So toxic syndrome together is known as toxidrome. This word was first coined by Moffenson and Greenshire. Okay, so what is toxidrome? It is a group of signs and symptoms which consistently result from a particular toxin. Okay, and to describe a better toxidrome, you should have the vital signs, you should have some end organ manifestations, and you require even few lab parameters to tell that yes, this person or a patient has consumed this type of toxin, right? So what are the end organ manifestations we are speaking about? The first one is your CNS. So we are going to check the mental status of the patient. We are going to check the ophthalmic system in the form of the pupil size. We'll check the gastrointestinal system function in the form of presence or absence of peristalsis, dermatologic system as whether the skin is dry or patient is diaphoretic, whether the mucous membrane is dry or moist, and the last is your genitourinary system in the form of urinary retention or the urinary incontinence. So these are the end organ manifestation in a toxidromic approach. Now, how to approach any patient who has present with an unknown poisoning? So the first important thing is history. So in history, a lot of things are required to come to a specific diagnosis, but three important things. One is what type of a drug overdose or the substance abuse the patient has taken. Second, whether this patient has a suicidal ideation or any prior suicide attempt. And third is whether there is a history of psychiatric illness. So these are the important things apart from the history which you usually collect, what type of drug, what is the amount, when did he consume, whether you went to the previous hospital, any gastric lavage given. Apart from all these three are a very important history that you should obtain from the relatives. Now coming to the vital examinations. So four things, your blood pressure, pulse rate, respiratory and temperature, they form one of the important vital signs in a toxidromic approach. So we'll discuss about each of it. So first is blood pressure. So you should know the mechanism of action, how this blood pressure presentation occurs in case of a poison patient. Now, drugs which cause hypotension or toxins which cause hypotension. So what is the mechanism behind that? One is there is decreased peripheral vascular resistance. There is myocardial depression in the form of decreased myocardial contractility. There could be arrhythmias and there could be a depletion of intravascular volume, all leading to hypotension with certain group of drugs. Now, second group of drugs is those drugs which cause orthostatic hypotension without causing any marked supine hypotension. Why does this occur? Because these drugs, they usually affect the autonomic control of the heart or the peripheral capacitance vessels. Now coming to those drugs which causes hypertension, especially your sympathomimetics. So how do they act? They act on CNS by causing sympathetic overactivity. They cause increased myocardial contractility and increased peripheral vascular resistance. So these are the mechanisms by which hypotension or hypertension results in case of a poisoning. Now, you should, when they ask about toxidromic approach and we write about each signs and symptoms, so about the vital signs, at least mention 5 to 6 drugs which causes either hypotension or hypertension. Important drugs. So hypotension, we all know beta blockers, calcium channel blockers, ARBs, AC inhibitors, okay, tricyclic antidepressants, ethanols, opioids, sedative hypnotics, most common drugs. These causes hypotension. Now, hypertension is caused by alpha 1 adrenergic agonists, ergot alkaloids, monoamino oxidase inhibitors, nicotine, and all the sympathomimetics. These cause hypertension. Now, the second important vital sign is your pulse rate. So, for a normal pulse rate, there should be a balance between your sympathetic as well as your parasympathetic tone. Reflex tachycardia usually occurs because of hypotension, vasodilatation, or because of the underlying hypovolemia. Reflex bradycardia occurs when there is an abrupt hypertension, which occurs occasionally. So, usually the tachycardia is common of two important poisoning, the sympathomimetic drugs and the anticholinergic drugs. But how to differentiate between the tachycardia when a patient comes with any other consumption? Okay, so in sympathomimetic toxicity, this tachycardia is usually accompanied by diaphoresis and increased bowel sounds. Whereas in anticholinergic toxicity, the tachycardia is usually accompanied by dryness, that is decreased sweating, absent bowel sounds, and there will be a urinary retention. So this is how you differentiate tachycardia, which is present in a patient, whether it is sympathomimetic origin or because of the anticholinergic toxicity. Okay, and one more thing you need to remember about the relation between the pulse rate and the temperature, because certain drugs cause hyperthermia leading to increased tachycardia. Okay, so the pulse rate increases approximately 8 beats per minute for each 1.8 degree Fahrenheit or 1 degree Celsius elevation in temperature. So now examples of the same. So examples, drugs causing or toxins causing bradycardia is your same. Alpha 2 adrenergic agonists, beta blockers, calcium channel blockers, your famous OP compounds, carbamates, opioids. Okay, so all these causes bradycardia. Coming to the tachycardia, anticholinergics, antipsychotics, tricyclic antidepressants, your methylxanthines, and the sympathomimetics. So these cause tachycardia. Now coming to the temperature, the third vital sign. So you call hypothermia when the temperature is less than 95 degrees Fahrenheit or less than 35 degrees centigrade, and hypothermia when the temperature is more than 100.4 degrees Fahrenheit or more than 38 degrees Celsius. So what are the common causes of hypertension? Common causes of hyperthermia. Okay, one is environmental heat stroke, extreme psychomotor agitation, or xenobiotic related temperature disturbances, which are usually seen with malignant hypothermia, serotonin toxicity, or your neuroleptic malignant syndrome. Okay, also, certain drugs which may contribute to hypothermia are anticholinergics, antiepileptics, antihistaminics, antihypertensives, antipsychotics, and diuretics. So usually, these environmental heat stroke, malignant hypothermia, they all result in life-threatening hypothermia, which may lead to extensive rhabdomyolysis, AKI, and sometimes direct liver as well as brain injury. Okay, whereas certain drugs like your ethanol, CNS depressants, and general anesthetics may cause hypothermia. So we've already discussed what causes hyperthermia and what causes hypothermia. The other examples of hypothermia are your general anesthetics, carbon monoxide, ethanol, hypoglycemics can also cause hypothermia. Now the fourth one is your respiratory rate. Okay, so what causes hyperventilation? What causes hypoventilation? So hyperventilation is usually caused by CNS stimulants like salicylates, which mainly acts on the brainstem. Whereas your bradypnea or hypoventilation is usually caused by your opioids, sedative hypnotics, and these also directly act on the brainstem, leading to decreased respiration. In case of cyanide or carbon monoxide poisoning, okay, the patient initially has a fast respiration, and as if you don't give the treatment and as the concentration of the cyanide and carbon monoxide increases, then there occurs bradypnea and slowly respiratory arrest. Now, causes of bradypnea. So your OP poisoning, carbamates, all your ethanols, okay, and your opioids, okay, all these lead to bradypnea, whereas tachypnea occurs usually in the earlier stages of cyanide toxicity, ethylene glycol toxicity, methanol ingestion, methyl xanthis, and in the early stages of nicotine consumption. So these are about the vital signs. Okay. So heart rate, BP, respiratory rate, and temperature. And what are the drugs that are causing each of this? So this is the first part of the toxidromic approach. Second is your end organ signs, which I've already mentioned. So we'll see which of these drugs cause the end organ findings. So first one is your ocular findings. So here you should know which are the drugs which causes miosis, which are the drugs which causes mydriasis. So miosis, your pupillary constriction, is most commonly caused by your barbiturates, OP compounds, carbamates, all types of alcohols, okay, and your physostigmine. All these causes miosis. Your mydriasis is caused by all your sympathomimetics like amphetamines, anticholinergics, antihistamines, cocaine, any drug withdrawals, MAO inhibitors. All these cause mydriasis. Now, second comes your mental status and behavior. Okay, your CNS. So you should know which of the drugs which causes CNS depression, CNS activation, and which causes delirium. Okay, so all of the sympathomimetics usually cause elevated mood, right? Whereas all your sympatholytics and cholinergics, sedative hypnotics, and narcotics, all these causes CNS depression. Whereas some drugs even cause delirium and confusion, like your alcohol or any drug withdrawal, anticholinergics, antihistamines, carbon monoxide toxicity, and salicylates. Okay, this is about the mental status. Now coming to the seizures. So which of the drugs which have seizure potential? Okay, the most commonest is your amphetamines and your anticholinergics. These both have a high incidence of seizures. The others could include your tricyclic antidepressants, your carbamates, your ethylene glycol, lithium toxicity, OP poisons, and your hypoglycemic agents. Okay, these are some of the examples causing seizures. Now coming to, this is about the end organ things, about two important. One is your CNS, one is your ocular manifestations. Next comes your laboratory investigations. Okay, so some important laboratory investigations which also help in toxidromic diagnosis are, first one is your anion gap. Okay, so anion gap, everyone knows the causes of elevated anion gap and your decreased anion gap or a normal anion gap. Okay, so I'm not going to go in detail about the causes of the elevated or decreased anion gap, as you all know that. So in the toxic ingestions, it would be ethylene glycol, methanol, paraldehyde, salicylate, and any of the alcohols. Okay. Now coming to the osmolar gap. This is very, very important. Okay. If the patients had an elevated anion gap, try to calculate the osmolar gap. So what is osmolar gap? It is measured osmolality minus your calculated osmolality. Okay. So calculated osmolality, I know you people know about the formula, which includes your sodium, urea. Okay. So yeah, coming to measured osmolality. So measured osmolality, this can be done by two methods. One is your vapor pressure osmometry, and the second one is freezing point depression osmometry. Okay, your vapor pressure osmometry usually does not detect volatile alcohols such as ethanol and methanol. However, it detects ethylene glycol. But for us, the most important ones are your alcohols, the common alcohols which are available. So the best way to measure these alcohols are your freezing point depression osmometry, which actually measures all of the solutes. Okay, so a osmolar gap, normal osmolar gap is less than 10 milliosmoles per kg. And if there is any increased osmolar gap, then the causes of that include ethanol, ethylene glycol, propylene glycol, sorry, glycerol, even your IV immunoglobulin because it contains maltose. That also causes increased osmolar gap, mannitol, methanol, any radio contrast media, and sometimes even hypermagnesemia. Severe hypermagnesemia also leads to osmolar gap. So anion gap, osmolar gap. The next gap is your oxygen saturation gap. Okay, so what is the oxygen saturation gap? It is the difference between the oxygen saturation, which is measured by your pulse oximetry, that is your SpO2, and the oxygen saturation level, which is calculated by your ABG, right? So the difference should be less than 5%. If it is more than 5%, then there is a presence of either carbon monoxide poisoning, methemoglobinemia, cyanide poisoning, or presence of hydrogen sulfide. Okay, so the best way to confirm this is your co-oximetry. Okay, so these are the three laboratory findings which are important for us. So one is your anion gap, one is your saturation gap, and one is your osmolar gap. Okay, now coming to the examples of these toxidromes. So when they ask about toxidromic approach, so first mention what is it. Second, you should mention about the vital signs and each of the vital signs examples. Second one be your end organ manifestations with examples. Third is some of your laboratory parameters examples, and you can just mention about one of the toxidrome which you actually know. Okay. So you can either mention about anticholinergics, opioid, narcotics, or any other examples in detail. Okay. Now coming to the first one, your anticholinergics. So usually they resemble sympathomimetics, and the most important, the mechanism of action is they block the acetylcholine by which it activates the nervous system through muscarinic and nicotinic receptors. Right. So now coming to the features. So we have seen all of the approaches. Okay, what causes what? So anticholinergics usually cause mydriasis, blurred vision, their temperature is raised, they cause dry skin flushing, they cause ileus, urinary retention, tachycardia, hypertension, sometimes psychosis, coma, seizures, and in rare cases, myoclonus. So coming to the drugs which cause all these. Okay, your antihistaminics, atropine, baclofen, benztropine, tricyclic antidepressants, phenothiazines, scopolamine, all these causes the anticholinergic toxidrome, where all these features are present in these type of toxins. So what is the drug treatment? So it is physiostigmine, but in case of tricyclic depressants, the treatment is different. Don't try to use physiostigmine in these cases because it causes life-threatening events. Okay, and also causes some conduction abnormalities in the heart. Okay, so these you have to write like this, one example in detail. Okay, so this is about anticholinergics. Second is your cholinergics. Okay, so you can write about your OP compound. So everyone knows about the OP compound. So you can give about the write about the OP compound. So cholinergic toxidrome. So you all know the features. You have the sludge, salivation, lacrimation, urination, diarrhea, GI cramps, and emesis. Okay, so drugs, your organophosphorus, carbamates, physostigmine, and pilocarpine are the drugs which cause cholinergic symptoms. So drug treatment, we all know atropine and pralidoxine. Now coming to the narcotics. Okay, so narcotics, the most common is your opiates. So these patients have a shallow breathing, altered mental status. Here it causes meiosis. There is bradycardia as well as hypotension, hypothermia, and decreased bowel sounds. So what is the antidote for this? It is naloxone. And how to give naloxone? What is the dose of naloxone also is very, very important. Okay. So the dose of naloxone is you need to dilute 0.4 mg in 10 cc of NS and titrate a patient, okay, till the patient starts breathing. Okay, so each ml contains 0.04 mg. Okay, so you have to give 1 ml every 2 minutes. Now, next comes your sedative hypnotics. So you have your benzodiazepines, barbiturates, anticonvulsants, antipsychotics. So all are included in your sedative hypnotics. So usually patient presents with stupor and coma, confusion, apnea, and slurred speech. So the drug treatment would be naloxone, flumazenil, and urinary alkalization for phenobarbital. Similarly, you have your sympathomimetics where you have your beta adrenergics, alpha adrenergic, and a combination of beta and alpha adrenergics. So when you have time, you can just go through it. The other toxidromes include hallucinogenics like your amphetamines, cannabinoids, cocaine. All this come under hallucinogenics, and your extrapyramidal toxidromes. Okay, rarely even haloperidol, respirin, and olanzapine may also lead to rigidity, tremors, hyperreflexias. Okay, so these are the examples of toxidromes which you have to write in your exams. Maximum two, but at least one in detail. Okay, so this is how you need to write when they ask about toxidromic approach of a unknown poisoning, right? So the others are serotonergic drugs and epileptogenic drugs. So these are very rare. So this completes the first topic. Now coming to the second one, paracetamol poisoning. Okay, so very, very important type of poisoning, most asked question in your exam. So paracetamol is usually anyl derivative and it has a lots of different names. It is also known as acetaminophen. It is also known as N-acetyl P-aminophenol. So what is the mechanism of action? It is a weaker or a selective inhibitor of your cyclooxygenase enzyme. Okay, it has anti-analgesic and antipyretic action, but it doesn't have a peripheral anti-inflammatory properties. Okay, so what is the pharmacokinetics or dynamics about the drug? So when they ask about any drug, so you should give the introduction as pharmacokinetics, pharmacodynamics. So when there is an ingestion of a therapeutic dose, so what happens? It is rapidly absorbed into your duodenum and it forms a weak acid. And your peak concentrations will reach within 30 minutes to 2 hours, and it has 100% bioavailability, and usually within 4 hours when you measure the serum paracetamol concentration, it will be around 10 to 20 mg per ml. It is around 20% protein bound, and the volume of distribution is around 0.85 liters per kg. The elimination half-life is around 2.5 hours. And as told, the therapeutic concentration for the antipyretic effect should be usually 100 to 20 mics per ml. Okay, I'm so sorry. This is mics here. So this is about the pharmacodynamics and pharmacokinetics of the drug. Now coming to the metabolism. This is very, very important for us because paracetamol toxicity usually involves this metabolism part of the drug. Okay, so there are two important ways by which the drug is metabolized. So the major form is by glucuronization or the sulfation process, where there is a production of some non-toxic metabolites which are usually eliminated in the urine. Around 5 to 10% of the drug is also metabolized to your NAPQI through the cytochrome P452E1 route. Okay, and this NAPQI is actually toxic. But because of the presence of glutathione in our body, this NAPQ is converted into the non-toxic form like cysteine and other compounds which are then excreted in the urine. Okay, so the normally around this part of a small amount, around 5 to 10% of NAPQ is formed. But because of the glutathione stores in our body, it gets converted to non-toxic forms and get excreted. This is the normal metabolism. Now coming to the toxicity. So how does paracetamol toxicity occurs? So when a lot of drug, okay, other than your therapeutic dose is being ingested, okay, so what happens? Your gluconization and the sulfation pathways become saturated, right? So most of the drug which can be metabolized will be metabolized, but the remaining drug will go into your second pathway, which is your cytochrome P450 pathway. So what does this do now? There is production of increased amount of your NAPQI. Okay. So this NAPQI, it cannot be completely neutralized by some amount of glutathione stores which are present in our body. Okay. Because there is a lot of NAPQ which is formed now. So what happens? The remaining part of the NAPQ which is present in the blood or in the blood will lead to oxidative stress and mitochondrial dysfunction, which leads to depletion of ATP stores, leading to hepatocellular necrosis and cell death. Okay, so this is what happens in case of your paracetamol toxicity. Okay, so this is the one. If you want to make it uh, more a better answer in your exam, so please you can put this diagram and you can mention. So paracetamol 80 to 90% glucuronide and sulfate conjugates are formed. Around 5 to 10% because of the cytochrome enzymes it is converted to NAPQ, okay, which is usually toxic. But because of the glutathione stores which are present in our body, it gets converted to cysteine and mercaptouric acid conjugates, which are usually non-toxic and excreted in the urine. Okay. So one more thing you need to mention when you're mentioning about the pathophysiology of paracetamol toxicity is, so paracetamol induced toxicity or hepatic injury is basically a centrilobular type of necrosis. Okay. So this is about the toxicity or the pathophysiology. Now coming to the toxic dose of paracetamol, which causes all this damage. So a single ingestion of more than 10 grams or 200 mg per kg, that could be leading to the toxicity. Second, more than 10 grams or the same 200 mg per kg over a 24-hour period as a staggered dose. Third, more than 6 grams or 150 mg per kg per 24-hour period for at least 2 consecutive days. Okay, so all these causes the toxicity, paracetamol toxicity symptoms. Okay, and in those patients who have already a acute liver failure, even the therapeutic dose which you give might also lead to toxicity. Okay, that is known as your therapeutic misadventure. Okay, so we have seen. So whether all these patients develop toxicity for paracetamol? No, there are certain risk factors which are important for the development and the manifestations of paracetamol toxicity. So the first risk factor is any ingestion of massive doses, like more than 30 gram. Okay, so that is one of the first risk factors. Second, if the paracetamol is together ingested with your alcohol consumption. Okay, because alcohol consumption will lead to CYP231 induction. Okay, which may lead to increased NAPQI formation. Also, in these alcoholics, there is poor nutrition and lower glutathione stores. Okay, so which further makes them more prone for toxicity even at lower levels. Any enzyme inducers, your P450 enzyme inducers, like your anti-seizure medications, can causes increased NAPQ production. Next, if the patient presents in the later stage, like more than 48 hours, or if the patient is consuming from modified release or extended release paracetamol, okay, or those patients who have prolonged fasting, who are malnourished or anorexic, so these patients have decreased glutathione depletion or stores are not adequate, so that is one of the risk factor. Repeated supratherapeutic ingestion and staggered overdoses, okay, and any genetic polymorphisms, and if there is a drug-induced liver injury which is already present and upon which you are giving a paracetamol, then that is also leading to a severe toxicity. So these are the risk factors. Now, next comes your risk assessment. In risk assessment, two important risk assessments are very important. One is your biomarkers and one is your Rumac-Mathieu normogram. Now, first, biomarkers. So these biomarkers, they usually determine the risk of toxicity. They're needed for the treatment and also to know how much the treatment is effective. Okay. So what are those tests or the biomarkers? One is your serum paracetamol concentration. Second, your LFTs. And third is your INR. Okay. So in this, your ALT and AST are very, very important. Okay. So paracetamol induced hepatotoxicity is generally defined as either AST or ALT elevations of more than 1000 international unit per liter. In severe toxicity, even the concentration may be elevated more than 10,000 also. And most important is your ratio, AST to ALT ratio, which is known as D-Ritis ratio. So normally, both rise in 1:1 ratio. But when you consume paracetamol, okay, at the presentation, if when you measure the ratio, it is more than 2, then it is associated with poor prognosis. Or suppose if it is not paracetamol poisoning, then it will be usually associated with chronic excessive alcohol ingestion. So this is not the specific biomarker for paracetamol ingestion, but in general, this is the one. When the ratio is more than 2, it indicates worse outcomes in cases of paracetamol poisoning. So next comes your Rumac-Mathieu normogram, very important one. So it helps in estimating the risk of liver toxicity and thus whether treatment with N-acetylcysteine is indicated or not indicated. Okay. So concentrations which are lying above the line, what is that line? I will let you know. Indicate that patients require acetylcysteine, and concentrations more than double the line indicates an even greater risk. So what is that? I'll show you in the next slide. And important thing you should remember is it is not useful to predict risk for either late presentations or the staggered or the repeated overdoses. So in such cases, you need not, your Rumac-Mathieu normogram cannot be used. Okay, so this is the one. Very, very important. So this is time since ingestion and this is the acetaminophen blood concentration in microgram per ml. Okay, so this was first given in 2012. Okay, so basically when do you start marking this Rumac-Mathieu normogram is it begins at 200 microgram per ml at 4 hours after ingestion. Okay, there it starts. Okay, so there are two lines which I've already spoken in the previous slide. One is known as the treatment line, also known as the safety line. So this is the line. So this begins at, if you see the concentration, it is 150 microgram per ml at 4 hours. Okay, which was derived at 25% lower than the original normogram line. Okay, now the second line usually begins double the dose, 300 microgram. So 300 microgram per ml at same 4 hours, okay, which was derived as 50% greater than the original normogram line to denote patients with increased risk of developing lung injury. Okay, so two lines. One is the treatment line, which is also known as safety line. Okay, and this is the high risk line. Okay, so 150, 300, both at 4 hours. Okay, so acetylcysteine should be initiated if a serum or plasma acetaminophen concentration, which is drawn 4 to 24 hours after ingestion, falls on or above the treatment line. Okay, on or above the treatment line. If any patient comes and you have measured, and the patient comes within 4 to 24 hours, you have measured the serum paracetamol level, and you should draw this normogram, and if it falls within the treatment line or above that, then you give N-acetylcysteine. If it falls below the treatment line, need not to give your N-acetylcysteine. Okay, but in most of the cases, we don't, your paracetamol levels are not available. So in such cases, okay, you can actually give your paracetamol, N-acetylcysteine if the patient comes within 4 to 24 hours. Okay. So this is just an arbitrary concentrations after the ingestion. So as I told, at 4 hours, usually the concentration of paracetamol will be more than 150. Similarly, at 24 hours, it will be more than 4 microgram per ml. So this is about the risk assessment. One is with the help of biomarkers and one is with your Rumac-Mathief normogram. Next, coming to the clinical presentation. So whenever you're writing a clinical presentation for paracetamol poisoning, it should be in stages. Okay, so it is stage 1, stage 2, stage 3 and stage 4. Stage 1 starts from 0.5 to 24 hours. So here some patients could be asymptomatic or could have some mild symptoms like nausea, vomiting, diaphoresis, pallor, lethargy and malaise. And when you measure here, mostly the laboratory tests could be normal. In stage 2, which is 24 to 48 hours, there is slowly some evidence of hepatotoxicity and even some nephrotoxicity that is present, and patient might be complaining of right upper quadrant pain because slowly the liver enlargement will be present. And those who are subclinical, your laboratory tests might become abnormal here. So your bilirubin, PT, and your liver enzymes may be elevated. Now in stage 3, which is 72 to 96 hours, very, very important period. So here your enzymes will rise to a very high levels. There is a lot of derangement in your coagulation profile. Along with this, the patient might have clinically hypoglycemia. There could be lactic acidosis. When you measure ammonia, it is on the higher side. And since there is coagulopathy, there could be bleeding diastasis, acute renal failure, jaundice, and even hepatic encephalopathy. So this is the most important period, okay? Because slowly, if the patient is worsening from this period, then death is most common in these patients. Now, stage 4, if the patients cross this period, which is from 4 days to 2 weeks, it is a recovery phase. Or if the patient is worsening or fits into a transplant criteria, then transplant can be done. Or if the patient worsens further, death. Okay, so past 4 days, all this can occur. And the symptoms and laboratory values may take weeks to normalize. So don't expect a to normalize all your lab parameters within this period. Okay, so this is a clinical presentation and you need to mention this in stages. Now coming to poor prognostic markers. Okay, so what are the poor prognostic markers? Your ALT levels more than 1000, INR more than 3. If the patient has AKI with oliguria, pH less than 7.3, lactates more than 3, and symptoms like hypoglycemia, thrombocytopenia, severe hypotension, and encephalopathy. All these are poor prognostic markers. Now, coming to the treatment. So, the first initial treatment, if the patient comes within 2 hours of ingestion, then the best way is to do a decontamination is by activated charcoal. Okay, so this activated charcoal usually binds paracetamol and reduces the amount of paracetamol absorbed from the GIT. So done only if the patient presents within 2 hours of ingestion. Suppose if there is a massive overdose or if the patient has consumed some extended release preparations, then you can also give gastric decontamination up to 4 hours. Okay. And some studies have shown that this charcoal may reduce the peak paracetamol concentrations, the need for NAC, as well as it decreases the risk of hepatotoxicity. Okay. Now, second one, the most important, the antidote, the N-acetylcysteine. So, how does this N-acetylcysteine act? Mechanism of action. So, it avoids toxicity by preventing the binding of NAPQI to hepatic macromolecules. How? Because it restores the glutathione. Okay, by replenishing the cysteine, which is the rate limiting factor for glutathione synthesis. And the risk of developing hepatotoxicity is reduced when you give NAC within 8 hours of ingestion. So according to the guidelines, it is within 8 hours of ingestion, but you can extend even up to 24 hours. Okay. So this is the mechanism as I told. So the steps are the normal. So glucuronization, sulfation will act and your P450 enzyme. So excessive amount will go to this P450 enzyme, which may lead to the production of your NAPQI. So what does NAC do? It increases the glutathione stores in the body and converts this NAPQI into the non-toxic products and these non-toxic products are getting excreted into the urine. Okay, so this is the mechanism of action. Now, indications, as I told, best within 8 hours, but can be extended to 24 hours. And it depends upon the levels. Okay. So 150 at 4 hours or 50 at 10 hours. And if it is an acute poisoning, okay, which is ingested within 1 hour with no other products containing acetaminophen in the past 24 hours, then that is an indication. Basically, not a staggered dose, then you can give N-acetylcysteine. Okay, acute poisoning with no ingestion of any sustained release formulations. So extended release or sustained release, then you can give NAC. Okay, and it's used, as I told, ideally within first 8 to 10 hours with risk of hepatotoxicity being less than 5%, especially if your paracetamol level is above the treatment line. So that is very, very important. Above the treatment line is also very, very important. Okay, and where this Rumac-Matthew or serum paracetamol levels are not available, then empirical use when these levels cannot be obtained within 8 hours of ingestion. So we all most probably give N-acetylcysteine as an indication. This is the last indication which we all give. Okay. Now this NAC can be available as oral or IV formulations. The most common we use is the IV formulation. So IV, it is available as 20% solution. In the oral, it is available as 20 as well as 10% solutions. So remember any one thing, just mention that it can be given orally or IV, but mention your IV dose. Okay, so the loading dose, it is 150 mg per kg in 200 ml 5% dextrose, which is given over 15 to 60 minutes. The maintenance dose will be 50 and then 100. So 50 over 4 hours and 100 over remaining 16 hours. Dilution is very, very important. 50 in 500 ml 5% dextrose and 100 in 1 liter 5% dextrose. Okay, so duration of therapy totally will be 20 or if it is 21 hours. So we should monitor for drug-related adverse effects and presence of any anaphylactoid reactions. So this is the flow chart which is showing about how to go with treatment of paracetamol poisoning with N-acetylcysteine if there is an availability of paracetamol concentration, measurement of paracetamol concentrations. So history is reliable and the patient has ingested and it come within 0 to 24 hours. Do the decontamination if possible. If the patient has arrived within 2 hours, then measure the paracetamol levels. Okay. So 0 to 4 hours, 4 to 8 hours, 8 to 24 hours, and more than 24 hours. Okay. So start N-acetylcysteine while waiting if ingestion is more than 30 gram or if acetaminophen concentration will return after 8 hours. Okay. So in such cases, you just plot the acetaminophen concentration, see whether the patient is below the treatment line, above the treatment line, or above the high risk line. So below the treatment line, no need to administer N-acetylcysteine. Above the treatment line, the normal dose of N-acetylcysteine. But if the patient is above the high risk line, okay, that is 300 mg in 4 hours, then some guidelines tell that you can give a high dose of N-acetylcysteine, but I couldn't find any high dose uh, regime for paracetamol toxicity. Or they tell you can give extended NAC. Okay, extended NAC. Just within 20 hours, you need not to stop. You can extend the NAC concentration until your patient improves. Okay, so this is above high risk line. Okay, so this is how you give N-acetylcysteine, and when to stop N-acetylcysteine is very, very important. One, when your acetaminophen concentration is less than 10 microgram per ml, your INR is less than 2, your AST ALT is normal for the patient, or if elevated, have decreased at least 25 to 50% the peak, and if your patient is clinically well. Okay, if all these criteria are met, then you can stop your NAC. Okay, if it's not met, you can give your extended NAC. So in your extended NAC, what you give is the last one. Okay, 100 milligram per kg over 16 hours. This is the dose you give in the extended NAC. Okay. Now, what are the other drugs which can be used in paracetamol toxicity? So initially they were even using methionine. Okay, but methionine has a lot of side effects, so they have stopped using methionine because that also provides glutathione indirectly. Now, second is your cimetidine. Now, cimetidine, fomepizole, both of these drugs, they inhibit your enzyme CYP2E1. Okay, so hence they saw that they have some role in paracetamol poisoning. And the last drug is your magnesium superoxide dismutase, okay, which is also known as calmangafodipir. Okay, so it is a mitochondrial protein which scavenges free radical and can prevent the mitochondrial injury, which is usually seen with paracetamol poisoning. So these are the other drugs which can be used if there is an availability. Okay. And the last one is in the treatment is your liver transplantation. So liver transplantation referral, we have your King College criteria. So what is the King College criteria for paracetamol poisoning? If the pH is less than 7.3, irrespective of the grade of encephalopathy, or if your prothrombin time is more than 100 seconds and creatinine levels more than 300 millimole per liter, and patients in grade 3 or grade 4 encephalopathy. Okay, so this is for paracetamol poisoning. So patients that undergo liver transplantation due to paracetamol liver failure have a good clinical outcomes with a 5-year survival rate was really good. It is 70%. But if those patients who actually require liver transplantation and we are not able to, patient is not able to go for it, then the mortality rate is up to 30%. Okay. So this completes your paracetamol poisoning. Now the last comes your extracorporeal therapies for toxin removal. Okay, so very, very important. So it is known as ECTR, extracorporeal toxin removal. Okay, so it represents a treatment modality which promotes removal of endogenous or exogenous poisons and supporting or temporarily replacing a vital organ. So what is the role of ECTR in poisoning? Okay, so one is if the patient has a life-threatening toxicity, okay, then you can give an option of ECTR to the patient. Second, if there is prolonged admission in the ICU with coma and mechanical ventilation, especially with barbiturate overdose, then in such cases you can give an option of ECTR. Third, any likelihood of permanent disability, especially with methanol overdose. Okay, loss of vision is more common with methanol overdose. If that is a case, then you can give an option of ECTR. And third, those patients they develop toxicity despite your standard supportive measures and your antidotes if available, still the patients is having life-threatening toxicity, then that is an indication for your ECTR. Okay. So when they ask ECTR, what is it? What is extracorporeal treatment definition and what are the indications? General indications. And third is you need to mention about something known as XTRIP. What is XTRIP? It is a multidisciplinary and a multinational collaborative which is known as extracorporeal treatment in poisoning work group, which has been established with the aim to clarify the role of ECTRs in clinical practice through the development of evidence and expert opinion based recommendations. Okay, so these are the group of people who are have done a lot of work on this extracorporeal therapies in toxins. Okay, now, so what are the properties of the toxins or the drugs? for an extracorporeal therapies. Okay, so 5 important properties you should remember. One is the molecular size of the drug or the toxin, the protein binding of the drug, volume of distribution, water solubility, and endogenous clearance. These are the 5 important properties of the drug if it has to undergo a extracorporeal removal. In addition, some technical aspects of the procedure may also determine the extent to which a drug is removed. Now, in short, what are the single line that you need to mention in your exams? Okay, so first one is molecular weight. We all know that smaller molecular weight substances will be able to easily get cleared off through the membranes, your dialysis membranes, more easily than the larger molecular weight substances. Okay, so your toxin should have a smaller molecular weight to get removed from an extracorporeal treatment. Second, protein binding. So if the drug is bound to the proteins, then the free form of the drug in the blood is less, so it cannot be removed. So it should be free. The protein binding should be less. Then only the drug can be removed easily. Okay. Third is your volume of distribution. So a drug with a large volume of distribution. What is volume of distribution? So when a drug is given, it goes and settles into the different organ systems or distributes into the different organ system. So if there is a large volume of distribution, they tell that if it is more than 1 liter per kg, then what happens? All the drug from the blood will go and settle in one of the organ. So it cannot be removed out from the plasma. So it is minimally dialyzed. So your volume of distribution should be less than 1 liter per kg to get excreted through the extra corporeal therapies. Okay, so small molecular weight, less protein binding, and less volume of distribution. Okay, next, water solubility. So we all know that the dialysate which is used for hemodialysis, it is in the aqueous solution. Okay, so it is water soluble. So any drug which has a high water solubility will be easily removed from the extracorporeal therapy. In other words, lipid soluble drugs will not be able to get cleared by an extracorporeal therapy. So there should be high water solubility. And the fourth one is endogenous clearance. Okay, what do you mean by endogenous clearance? So, all of our drugs in the body get metabolized either through renal or non-renal mechanisms. So, in non-renal, the most important one is your hepatic clearance. Okay. So, your endogenous clearance should be less if the drug has to be removed by a dialysis or any other extracorporeal therapy. So dialysis will have a limited impact if the rate of drug removal is significantly faster by endogenous routes. How much fast? More than 4 ml per kg per minute. Okay, so endogenous clearance should be less. So these are the 5 important characteristics of the drugs that you should know when they ask about the extracorporeal removal. Done? So coming to the this basically different methods by which we can do this extracorporeal therapies are hemodialysis, hemofiltration, and hemoperfusion. I'll come it in the later slides. So this is nothing but the molecular weight. So if the molecular weight is less than 500 daltons, it can be easily removed by hemodialysis. For hemofiltration and hemoperfusion, even if you see kilodaltons it is. So high molecular weight toxins can be removed by hemofiltration and hemoperfusion. Now protein binding, as I told, it should be low. So if it is low, then it can be removed by hemodialysis. Hemofiltration also, the protein binding should be less. But if it is a hemoperfusion, even if the toxin is highly protein bound, you can remove it with hemoperfusion. Now coming to the volume of distribution. So everywhere if you see, it should be less volume of distribution. Solubility, yes, it should be water soluble, but hemoperfusion can even remove your lipid soluble drugs. And endogenous clearance for all, as I told, it should be less than 4 ml per kg per minute. Okay. Now, as I told, modalities. So one is your intermittent hemodialysis. Second is your CRRT. Third one is your hemoperfusion. Fourth one, even with therapeutic plasma exchange, where your immunoglobulins can be removed. Okay, so these are the four methods of extracorporeal treatment for the removal of the toxins. Now, just you should write at least 1 or 2 lines about the advantages of this type of extracorporeal removal for toxins. Okay, so we all know that hemodialysis, intermittent hemodialysis, is basically a diffusion which is against the concentration gradient. Okay, so you all know about the mechanism. Okay, so for drug removal, there are two types of intermittent hemodialysis. One is the standard one, and second one is the high flux modalities. Okay, so in high flux modalities, usually the pore size will be bigger, the dialysate flows will be higher. So the amount which can be removed is much higher in the high flux modalities. But the only drawback with this intermittent hemodialysis is after stopping the dialysis, there will be rebound toxicity. Okay, that is a main drawback of intermittent hemodialysis. So how to prevent this rebound toxicity? Either you increase the frequency of the sessions in a day, 2 to 3 dialysis, or you better shift it to a CRRT. So first for a day or two you do IHD, then shift to CRRT if possible. Okay, so this is the first choice extracorporeal modality which can be available everywhere. Okay, and it has a rapidity of toxin removal, but the thing is it only removes the low molecular weight toxins. Okay, so that is about the intermittent hemodialysis. Now coming to your CRRT, CRRT can remove higher molecular weight substances. 20,000 to 40,000 Dalton substances can be removed through CRRT. And the important advantage is here, the rebound of toxins will be comparatively less as seen in intermittent hemodialysis. Okay, that is the advantage. But disadvantage is that its efficiency is very low compared to IHD. Okay, and here you will require an intensive anticoagulation. So there will be an increased bleeding risk and electrolyte disturbances, and it will not be available in all the hospitals, and training and cost is the other disadvantages of CRRT. Now coming to the hemoperfusion or hemadsorption. So here usually it consists of a passage of anticoagulated blood through a cartridge which contains an adsorbent material like your activated charcoal or a resin. Okay. So in order to be removed by hemoperfusion, the toxic substance must have binding affinity to the sorbent in the cartridge, and it should have a low volume of distribution. So as I told, for hemadsorption, it can remove both water and lipid soluble substances, and also those substances which are highly protein bound, they can also be removed by hemoperfusion. So these are the two advantages. Lipid soluble drugs and high protein bound drugs can be removed by hemoperfusion. Okay, and centrifugation technique, as we all know, basically centrifugation, it separates the whole blood into various components according to their specific gravity. So in the treatment of a poisoned patient, the guidelines recommend an exchange volume of 1 to 2 total plasma volumes per day until the clinical symptoms have decreased and the release of toxin from the tissue is no longer significant. So this also can remove highly protein bound poisons. And also, if you see, the molecular weights over 50,000 Daltons can be removed by your centrifugation techniques, especially your monoclonal antibodies. But if you ask me the efficiency, it is very, very poor. Okay, so the clearance capacity is very much low compared to your other forms of extracorporeal removal. Okay, so other than your monoclonal antibodies, some support for this centrifugation process is your mushroom toxicity, thyroxine toxicity, vincristine and cisplatin toxicity. These can be removed with the help of centrifugation because the molecular weight of these are more than 50,000. So this is how you approach. If you think of any patient to subject to extracorporeal removal of toxin, then you need to answer all these questions and then fix upon what type of uh, modality I should use. Okay. So first one is the exposure to poison likely to cause any serious morbidity or mortality? The indications which I told. If it is yes, okay. The second is there any antidote which is present for this toxicity? If there is no antidote, then comes, can the poison's toxicity be minimized by treatments that prevent absorption and or enhance elimination? If it is no, then comes your first. See whether the poison's endogenous clearance. So first comes your clearance, second comes your volume of distribution. Okay, third comes how much is it protein bound. Okay, if it is more than 95% protein bound, less than 80, between 80 to 95. If it is more than 95% protein bound, then it is therapeutic plasma exchange that you need to do for that poison. If it is less 80 to 95%, then it is hemoperfusion. If it is less than 80, then you should check the molecular weight of the toxin. If the molecular weight toxin is much less than 500, intermittent hemodialysis, up to 15,000, high flux hemodialysis, 15 to 25 kilodalton, hemofiltration or your CRRT, 25 to 50, hemoperfusion, more than 50, therapeutic plasma exchange. So this is how you need to go about when you think of extracorporeal toxin removal. Okay. So now examples. A lot of drugs can be removed extracorporeally. So you have your aspirin, digoxin, lithium, paraquat, beta blockers, barbiturates, methanol, tricyclic antidepressant, sodium valproate, carbamazepine. So this is the table which gives you about the drugs that can be removed, what are the indications, what are the other forms of treatments that are, or the antidote which is present for this drug. So if you have time, you can go through it. Otherwise, I have given one last slide. If you remember that last slide for the exam, it's more than enough. And this is the one important thing that you should remember. The XTRIP group, which I mentioned before, has recommended, okay, against the use of extracorporeal therapies to tricyclic antidepressants and digoxin. It has a neutral opinion on phenytoin. It is can be used for acetaminophen and carbamazepine, but they have 100% recommended for your barbiturate toxicity, lithium, methanol, metformin, salicylates, thallium, theophylline, and valproate. So these are the only drugs which is been recommended by the extric group to be removed by extracorporeal therapies. Okay. So this is the last slide which tells about the indications of extracorporeal therapies for some important drugs which I have discussed, the recommended drugs. Okay. For toxic alcohol, what are the concentrations? Okay. That is especially for your methanol. Second, for salicylate, what should be the concentration? And if the patient has underlying kidney disease, what should be the concentration of the salicylates? Okay. Acetaminophen poisoning, lithium, metformin, and your lithium and metformin. So if you write any one of these when they ask about extracorporeal removal, one drug and its indication, if they ask for 5 marks, so you're going to write the definition, you just mention about the extrip group, indications, and the properties of the drugs. Okay, the 5 properties, very, very important. Then comes your uh, different modalities by which you can remove, and you can write about indications of 1 or 2 drugs. Okay, so that will complete the 5 mark question. Okay, thank you.
Thank you, ma'am.
Thank you.
So I think so. We have run through a few major topics in toxicology. We'll be continuing with a few more topics in trauma and toxicology also. I'll be starting with the next topic.
Darshan, 1 second. So if people have any doubt, you can put it in the chat box. Okay, we are going to answer it there. Okay, thank you.
Sure. Are my slides visible?
Yeah, visible, Dash.
Okay. Okay. So, continuing with the next topic, please bear with me for another couple of minutes, which I'll start with burns, and then you have to listen to five other topics which I'll be dealing with today. I think so. We have already given you the details of that. So, in the exam, when you're looking and listening to all of this, because you guys wanted notes, please try and have some sort of key words, okay, when you read about a particular topic. So when you want to recall, the more you recall a keyword, it will be easier for you to write down the answers in particular, especially in the previous topic about extracorporeal therapy in toxicology, the slide which went about the the flow chart. So if you remember the keywords there about volume of distribution, protein binding, molecular weight, etc. So these things will help you formulate your answer in a better way. Okay, that is what I want you guys to understand. So this whole session is to help you guys pick up those keywords as in when possible. Burns, coming to the topic per se, it's a big topic. So what are the questions that can be anticipated from burns is assessment and management of burns, burns shock, fluid therapy in burns, and role of colloids. These are a few things I thought would be asked. Majorly, it can be asked in both practical and theory as well. So, coming to the definition of burns, burn is nothing but a coagulative destruction of the skin and its structures. It can be caused either by physical, chemical, electrical, or mechanical energy. A major burn is defined according to the percentage of the total body surface area which has been affected by the injury. Usually, a burn greater than 25% of total body surface area is considered as a major burn in an adult more than 16 years. Okay, I'll be mentioning about further details about which are the other component of major burn in the subsequent slides. Okay, so again, a lot of other factors come into picture when we have to label a burn as major or minor. So coming to classification, if we have to do that, how do we classify? So burns are usually classified based on depth, etiology, percentage of total surface area involved, or it can be a combination of any of this. Why is it important? Because this is what which will guide us for treatment management. Okay, assessment of the severity will let us know which patient can be managed as an outpatient department, or the patient needs to be admitted in the wards or a particular burns center. Okay, so that is where this classification, categorization, all this will come into picture. So, as I told you earlier, burn is nothing but a destruction caused by any of these parameters. It can be either electrical, it can be friction, thermal, or chemical. So, again, they are subcategorized in electrical as high voltage and low voltage, chemical as acid and alkali, and thermal you have contact, flame, and scalds. Scalds are something because of fluids, hot fluids especially. Flame is direct exposure to the flame itself. It's quite straightforward. Contact is usually due to exposure to a very hot surface. Okay, it can be a hot plate or it can be a stove, etc. Okay, so these are the things which are the causes for burns. Okay, based on etiology. So coming to the next part of burns, that is pathophysiology. So what usually happens? Burns is a complex traumatic event involving the etiological factors, as I mentioned earlier. What happens after this? Because of a complex traumatic event, there will be tissue destruction. Okay, and this tissue destruction triggers a localized and a systemic response, which is characterized by a dysregulated inflammatory response. Okay, so this is similar to what we see in sepsis. Okay, this dysregulatory inflammatory response initially causes a hypermetabolic phase and follows through a hypermetabolic state. Okay, then they will have a lot of subsequent sequelae which happens because of SIRS or dysregulated inflammatory response, which causes injury. Usually, one particular organ will get involved, and if the SIRS response is very overwhelming, it can lead to a multi-organ dysfunction. Okay, this is usually how the pathophysiology of burns follow. Burns can be classified into two phases. Okay, especially if you're talking about burns shock, both of this you can write these two phases. Okay, so burns or burns shock, usually you'll have a ebb phase following a flow phase. Majorly when we are categorizing an ebb phase, it is supposed to be a hypometabolic. Okay, so it can be hyperdynamic, but it is still hypometabolic. Okay, so what usually happens when you have an injury? the body's initial response would be to increase vasoconstriction, because of which there will be increased systemic vascular resistance. There will be a sympathetic response causing increased surge of catecholamines, ADH release. And because of all of this, there will be hemoconcentration. And all of this in the initial phase, okay, there will be capillary leak which sets in. Because of capillary leak, what happens? There will be loss of intravascular fluid into the space around the tissue. Okay, that causes edema, and in long term, if the burns is quite extensive, can cause hypovolemic shock, leading to organ perfusion derangements, leading to ischemic insults. Okay, so both these things can happen simultaneously. That is your capillary leak causing hypovolemic shock, causing multi-organ failure. Okay, so along with this, there will be a compensatory vasoconstriction trying to improve the cardiac output. Remember, in the first 26 to 48 hours period, usually the cardiac output will be low. That is the phase of Burns shock. Okay, so that is your ebb phase. After this, if you have done a proper resuscitation, the patient would switch from an ebb phase to a flow phase. Okay, so in flow phase, what usually happens, there will be some amount of regeneration happening. That is the reason there will be increased oxygen consumption, protein wasting, because there is shift of metabolic pathways. Okay, and then at this particular time, the sympathetic response would have come down, and there will be some sort of normalization of cardiovascular inputs. Okay, so there will be decreased SVR, normalization of cardiac output, better perfusion, etc. So this is the normal way how a Burns pathophysiology would progress. Initially, you will have a ebb phase followed by a flow phase. Okay, so if you're looking at the Burns pathophysiology shock, and you're looking at the injury per se,
Hello, sir. You are not audible, sir.
Okay, so now we'll just go with some two important ops topics. Okay, so the remaining part of poisoning will be continued later. So in the ops topic, two important topics. One is your eclampsia and pre-eclampsia, that is your hypertensive disorders of pregnancy I'll be taking, and the other one is your postpartum hemorrhage. Okay. So the outline of the topic would be the physiological changes in pregnancy that are actually related to your PIH, the definitions, the pathophysiology, the screening and diagnosis, and last one would be the management. So the physiological changes which are very, very important for the PIH are first the hemodynamic changes. Okay, so this has been divided into first, second, and third trimester and during labor. So in the hemodynamic components, your cardiac output. So your cardiac output will be slightly elevated in your first trimester compared to your baseline. Second trimester, a little higher. Second and third trimester, and during labor, your cardiac output will be at the highest. Now coming to your systemic vascular resistance. It is reduced in the first trimester, comparatively further reduced in your second and third trimester. Heart rate, it is usually increased during third trimester and labor because of the labor pain that is present. But coming to your BP changes, if you see in the first and the second trimester, your BP is actually on the lower side compared to the normal BP. And in the third trimester, it could be usually normal. Okay. So these hemodynamic changes are very, very important to further go into the topic. Now, what happened to the systolic BP? As I told you, BP will be lower compared to the normal BP. So, systolic blood pressure will be decreased by 4 to 6 mmHg. Diastolic blood pressure will be decreased by 8 to 15 mmHg. Your mean arterial pressure will be decreased 6 to 10 mmHg. Whereas your heart rate, as I told, will be increased. Your stroke volume and your cardiac output both will be increased. Now coming to the spectrum of this hypertensive disorders. Okay, so what is how so the main important factor is your BP. So any pregnant lady with a systolic blood pressure of more than or equal to 140 mmHg, and sorry for this, the diastolic here should be more than or equal to 90 mmHg. Okay, so systolic more than or equal to 140, diastolic more than equal to 90. Then see the gestational age of the patient. Okay, so whether this pregnant lady's gestational is less than 20 weeks or more than or equal to 20 weeks. Suppose if it is less than 20 weeks and the patient has a BP of this much, then that is known as chronic hypertension. Okay, suppose if the gestational is more than or equal to 20 weeks, then you should see whether there is any target organ involvement or not. If there is no involvement of a target organ, then that is known as gestational hypertension. But if the BP is on the higher side, the gestational age is more than 20 weeks, and there is any target organ involvement, then that is your preeclampsia, eclampsia, and your HELP syndrome. Okay. Now coming to the gestational hypertension. So this also depends upon three important things. One is if the hypertension persists more than 12 weeks postpartum. So patient came here at around 26 weeks. There is no target organ involvement. BP is on the higher side. You have diagnosed as gestational hypertension. Post delivery, when you measured after 12 weeks, still the patient's BP is on the higher side. That is known as chronic hypertension. So you have two definitions for chronic hypertension. Suppose what, depending upon the gestational age. Okay. Now second group comes if the hypertension persists less than 12 weeks postpartum, that is known as transient hypertension of pregnancy. Whereas this gestational hypertension who doesn't have a target organ involvement, around 10 to 50% slowly progresses to involve one of the organs, and that time again you need to call it as preeclampsia, eclampsia, or HELP syndrome. Okay. Okay, easy way to remember the definitions if you just put this diagram. Okay. So you came to know about the definition of chronic hypertension and gestational hypertension. So I'm not going in detail about this. So we will go to the other definitions. So preeclampsia and eclampsia. So this preeclampsia can be further divided into without severe symptoms, with severe symptoms. So without severe symptoms, systolic BP, diastolic BP, yes, which is measured at least 2 occasions, 4 hours apart, gestational age of more than 20 weeks with proteinuria. So how much should be the proteinuria? Very, very important. More than 300 mg on 24-hour urine protein collection, or if you are doing the dipstick, 0.3 mg or 2 plus dipstick. Okay. Or women with new onset hypertension 48 hours to 6 weeks after delivery is also known as preeclampsia. Now with severe symptoms. So with severe symptoms means along with the proteinuria, there is evidence of end organ injury. If there is an end organ injury, then it is severe preeclampsia, or your BP is more than or equal to 160 mmHg systolic BP, and your diastolic BP is more than or equal to 110 mmHg on at least 2 occasions 4 hours apart, or persistent severe hypertension requiring IV antihypertensives to control your systolic or the diastolic blood pressure. Okay, this is with severe symptoms. End organ failure, severe symptoms, or your BP is more than 160 by 110. That is severe features. Okay, this is about preeclampsia definition. So as I told here in the previous one, gestational hypertension with one of the end organ involvement. So from that time I'm telling end organ involvement, end organ involvement. What is this? Okay. Any neurological complications, like if the patient has eclampsia, altered mental status, development of stroke, blindness, severe headaches, or persistent visual impairment, then that is end organ involvement in the form of CNS involvement. Second, respiratory pulmonary edema. Third, hematological, your HELP syndrome or any DIC. Fourth, kidney AKI. Fifth, liver involvement in the form of elevated aminotransferases or right upper quadrant or epigastric pain. And fifth one is related to the fetus, that is the uteroplacental insufficiency. Okay, if any one of these is present, then it is a severe preeclampsia, end organ involvement. Okay, so that is about your preeclampsia. Now, what is superimposed preeclampsia on chronic hypertension? Okay, so it is nothing but sudden worsening of BP control and need to escalate your antihypertensive therapy, or a new onset of proteinuria or a sudden increase in proteinuria in a patient with a known proteinuria. New onset or sudden increase in proteinuria, or significant new target involvement which is consistent with preeclampsia, that is more than 20 weeks of gestation or postpartum. Okay, I think you need not remember this, not much important. Just gestational chronic hypertension, gestational hypertension, the different types of gestational hypertension, and what is preeclampsia and eclampsia. More than enough. Okay, but you should remember the definitions. When you are writing the definition, you should write BP of this much measured on 2 occasions, 4 hours apart. Everything has to be mentioned. You can't mention just BP this much is with 20 weeks of gestation is preeclampsia. No. Okay, so your definition should be proper enough. Now coming to eclampsia. Eclampsia is a severe life-threatening manifestation of preeclampsia. So here, usually if the patient has seizures, so a preeclamptic seizures, having a preeclamptic patient having seizures is eclampsia. So convulsions during pregnancy or during postpartum, which could be tonic-clonic, focal or multifocal, new onset, unexplained by other neurological pathology, and associated with headaches or visual changes prior to a seizure. Okay, so these are the features of convulsions which a eclamptic patients has. Okay, and you should consider other underlying cerebral condition if the seizure occurs 2 to 3 days postpartum, and patient even on magnesium sulfate, if the patient has seizures, then you should think of the other causes like press or some other things. Okay, icy bleed. Okay, so that other causes has to be thought of. Okay, so these are just the differences between preeclampsia, chronic hypertension, superimposed preeclampsia and chronic hypertension. If you have time, go through it. Otherwise, you can just skip this slide. Okay. Now coming to the risk factors. Okay, so who are the risk factors who may develop preeclampsia? Okay, so you have high risk factors, you have moderate risk factors. So a lot of guidelines, they mention different risk factors. So remember one guideline, okay, your ACOG guidelines, most common guidelines. So what are the high risk factors? So if there is any history of preeclampsia, previous preeclampsia, chronic renal disease CKD patients, if the patient is chronic hypertensive, diabetes mellitus, or if they have any autoimmune disorders like your SLE or the antiphospholipid syndrome. These are the high risk factors. And even multiple pregnancies, that is also high risk factors for preeclampsia. Now coming to moderate risk factor. So primies are at a high risk, okay, and especially if the age is more than or equal to 40 years. Initially it was more than or equal to 35. Now I think because of the delayed pregnancies which are happening, I think they have extended it into age more than or equal to 40 years. If the patient is obese, BMI more than 35, inter-pregnancy interval of more than 10 years, and if there is any family history of preeclampsia. Okay, so these are the moderate risk factors for development of preeclampsia. Now coming to the pathophysiology. So just if when they ask pathophysiology, if you write this flow chart, that is more than enough, because to know in detail about the pathophysiology, I think it actually takes 5 to 6 slides, but we have just minimized to a single slide. So pathophysiology usually begins with first word you should mention is there is abnormal placentation. What do you mean by abnormal placentation? That is, the trophoblasts fail to properly invade and remodel the spiral arteries. In order to know this in detail, you have to go through the normal remodeling or the placentation process. But just for the exam sake, so just think, write it as abnormal placentation. What do you mean by abnormal placentation? So what happens when there is an abnormal placentation? There is placental ischemia. Okay, so this placental ischemia, it triggers the release of some placental factors like anti-angiogenic proteins, which is known as SFLT1. Okay, that is released into the maternal circulation. So what does this protein do? It leads to maternal endothelial dysfunction, which is characterized by vasoconstriction and reduced blood flow. Okay, because of all these changes, you have the hallmark symptoms of the preeclampsia, like new onset hypertension, end organ damage, like proteinuria, kidney liver function dysfunction, and in severe cases, even HELP syndrome. Okay, so please mention abnormal placentation, placental ischemia, release of anti-angiogenic proteins, which leads to endothelial dysfunction. What happens if there is an endothelial dysfunction? Vasoconstriction. So vasoconstriction causes hypertension. Vasoconstriction in other organs causes AKI or liver dysfunction or any other thing, and the reduced blood flow, right? So this is the pathophysiology. So if you want more marks, you can write the stages. Okay, the same thing is divided into two stages. One is the placental dysfunction and second is the maternal endothelial dysfunction. The same thing only. So you can just put one flower bracket and write it as placental dysfunction and the maternal endothelial dysfunction if possible. Okay, the same thing which I have told. Improper trophoblast invasion, failure of remodeling, placental ischemia. This in detail I've just mentioned it. Then release of anti-angiogenic factors, impaired angiogenesis and widespread vasoconstriction leading to end organ damage. Okay, simple. Now coming to the diagnosis. So what are labs you need to send in any suspected case of preeclampsia? Okay, so you need to send your CBC. Okay, so usually if there is an hemo concentration, it supports the diagnosis of your gestational hypertension without proteinuria. Then platelet counts, if it is less than 1 lakh, then yes, this patients might be even going into HELP syndrome. Your liver enzymes will be usually elevated. Serum LDH will be elevated. And in urine analysis, you're going to see your proteinuria. Measure your urine albumin creatinine ratio, 24-hour urine collection for proteinuria, and your serum uric acid will be elevated in some cases of gestational hypertension, and AKA, as I told, serum creatinine levels. So these are the routine labs which you send for a patient of preeclampsia. Now, important is your screening of preeclampsia. So at what stage you have diagnosed this patient has preeclampsia, and how to treat this patient is important. Okay, so only important points. Okay, so first trimester. Okay, so you usually you screen for the patients. Okay, they come for ultrasound or something, so you screen for the patient. So screen at 11 to 13 weeks of gestation, any pregnant lady. Okay, so what you do is you do the uterine artery pulsatility index you're going to measure. Okay, that would be the better one. Okay, see for the risk factors, measure the BP, and if possible, you do the Doppler of the uterine arteries. Okay, so patient is at high risk of preeclampsia, then please start. If you have diagnosed the patient as preeclampsia at this period, you start aspirin. You start aspirin. Okay, start before 16 weeks of gestation and you stop at 36 weeks of gestation. Okay, so this is the recommended treatment. So blue color is the recommended treatment if you diagnose patient in preeclampsia in the first trimester. And all the other pink ones are under development and resource dependent. Okay. Now, if you have diagnosed the patient at second trimester, okay, then you need to increase monitoring at 24 to 31 weeks of gestation. Okay, so monitoring, only monitoring is required. Similarly, if you diagnose it in the third trimester, you require proper monitoring and then think of expectant management, whether delivery is required or you can extend the pregnancy. Okay, so this is how you screen the pregnant lady. So each stage, suppose this patient here is at low risk, it might go for a high risk in the second trimester. Okay, so 3 times you need to screen these patients for preeclampsia. Okay. Now, as I told, role of aspirin in preeclampsia. Okay, so it is the ASPIRE trial. So it is aspirin for evidence-based preeclampsia prevention trial. Okay, so this was a multicentric RCT. Okay, uh, where the trial included around 1700 women at high risk were identified by means of combined screening with the algorithm. There is one algorithm which is present, so they have identified that. So the convincing evidence that daily aspirin from the first trimester, it reduces the risk of preterm preeclampsia by 62% with no significant defect on the rate of term disease. And now if you see, most of the patients, even though they are not preeclamptic, as a routine, most of the obstetricians are actually prescribing aspirin for the patients. Okay. So that has become one of the now recommended drug in pregnancy. Okay, aspirin. Even though if the patient doesn't have any signs of preeclampsia. Okay, so ASPIRE prevention trial you need to remember. Now coming to the management. So management includes control of the BP and then about the delivery part. So what are the drugs that can be safely used in pregnancy? Okay, so the most commonly used drug is your centrally acting alpha-2 adrenergic agonist, that is your methyl dopa. Okay, so it inhibits vasoconstriction. So as I told, vasoconstriction is the main mechanism. So it inhibits vasoconstriction via central mechanism by reducing the catecholamine release. So this decreases the central sympathetic flow, which further decreases your systemic vascular resistance without decreasing your cardiac output. That is also very, very important. There is no impaired uteroplacental circulation and hence this is not teratogenic. Hence this is one of the drug in pregnant ladies to decrease the BP in preeclampsia. There are some side effects like fatigue, there is depression, poor sleep, dryness of mouth, and in around 5% patients there could be an elevated liver enzymes. Okay, so this is the first group of drugs, the methyl dopa. Suppose if methyl dopa is not available or contraindicated, you can also try your other centrally acting alpha-2 agonist, that is your clonidine. Okay, so clonidine can also be tried similar to methyl dopa with regards to safety and efficacy. So preferred drug is methyl dopa, not available, any contraindications, then you can use clonidine. Okay, that is the first group. Now second group is your peripherally acting adrenergic receptor antagonists. Okay, so the most commonly used, which we all use, is the labetalol. So labetalol is a non-selective beta blocker with vascular alpha-1 receptor blocking properties. Okay, so what are the side effects with labetalol? It causes fatigue, lethargy, exercise intolerance, sleep disturbance, bronchoconstriction. They tell it is not teratogenic, but some studies have shown that there is some fetal growth restriction and low placental weight in patients who are on atenolol during the second trimester. Okay, so only drug that is better to be avoided in beta blockers will be atenolol. Otherwise, labetalol is very good. There is no teratogenic properties for labetalol. Okay. Now, second, coming to your prazosin, not most commonly used drug because it causes a lot of postural hypotension and palpitation. It is best used for those patients who have an underlying chronic kidney disease and then have a preeclampsia. Okay, such cases, prazosin would be a better option. Okay, so this is the second group. Now, third one is the calcium channel blockers. Okay, so the most commonly used calcium channel blockers are your oral nifedipine and the verapamil. Okay, so these are the second line agents. If the other drugs are not available, they are also not teratogenic. Okay, so mechanism of action, we all know, inhibits the influx of calcium ions to vascular smooth muscles, resulting in arterial vasodilatation. Okay, side effects, tachycardia, palpitations, peripheral edema, headache, and facial flushing. It is most of the drugs are class C drugs. Okay, no one is class A and class B. So every drug has some issues. So risk versus benefit is very, very important. Okay, the advantages of calcium channel blockers are it's compatible with breast milk. Okay, next group comes your direct vasodilators. Okay, like your hydralazine. Okay, so how it acts, it relaxes your arterial smooth muscles. Okay, this is also class C drug. It is not teratogenic, but there are a lot of side effects which are seen in the mother. Like it has severe headache. It causes very severe headache, nausea, and palpitations. Rare cases, they told that you can find neonatal thrombocytopenia. Okay, but it is very rare. Now coming to the last group of drugs, your diuretics. The use of diuretics in pregnant lady is controversial because it causes reduced plasma volume. Okay, but those patients who are already on maintenance diuretic therapy prior to pregnancy, they can be continued on this regime unless they develop premonitory signs of preeclampsia such as proteinuria. In such cases, stop the diuretic medications due to the concern that with the lower plasma volume characteristics of preeclampsia, further if there is hypovolemia, it may lead to stimulation of your renin-angiotensin system and it might worsen your hypertension. Okay, so diuretic role is still controversial. So these are the group of drugs which can be used in pregnant ladies for preeclampsia. As I told, for central actions, the preferred agent is methyl dopa. Alternatively, you can use clonidine. If you see, most of the drugs are C, 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 C. Okay, rarely it is B. Okay, then in beta blockers, preferred is labetalol, better to avoid atenolol. Calcium channels, preferred is nifedipine, alternative would be your verapamil. Then your direct vasodilators, diuretics, and important is contraindications. What is contraindicated? Your AC inhibitors are or ARBs are contraindicated in pregnancy because it is causes congenital heart defects and kidney defects in the fetus. Okay. So don't use, as I told, atenolol, propranolol, and your AC inhibitors and ARBs. Okay, so these are all the effects which will be seen on the fetus. Okay, so these are the dose of drugs that are available. Okay, so just remember about labetalol because we use it regularly. If possible, remember the dose of uh, methyl dopa. Not usually routinely used, but at least one of the drugs dose has to be remembered. Okay, so next, coming to the BP threshold. So when should you initiate treatment for preeclampsia, antihypertensives, and what should be your target? Okay, so there are lots of guidelines and societies which they have mentioned. So our thing is ACOG guidelines 2022. So what is the BP threshold for initiating treatment? So for a chronic hypertensive patient, your BP target is more than or equal to 140/90. For acute hypertension patient, the BP target is more than or equal to 160/110 mm Hg. But target treatment, I mean treatment target till how much you should get is not been specified by your ACOG. Okay, but your other societies have mentioned some of the targets. Like the International Society for Study of Hypertension in Pregnancy 2018 told that at least your systolic BP should be around at least around 140 and your diastolic BP should be around 85. Similarly, the other guidelines also, it is around 135/85 or 140/85. So target it as 140, less than 140 and less than or equal to 85 should be your treatment target. Okay. So then comes your seizure prophylaxis. Okay. this is still, this patient has no seizures. But is there a role of seizure prophylaxis in preeclampsia patients? So we are going to see. Okay, so what is the seizure prophylaxis usually we give for eclamptic patients? It is the magnesium sulfate. So magnesium sulfate is effective in the prevention as well as treatment of eclampsia in women with preeclampsia with severe features. So any patient with preeclampsia with severe features, you can give seizure prophylaxis in the form of magnesium sulfate. Okay. It does not prevent the progression of other organ involvement because of preeclampsia unrelated to seizures. Okay. The role of seizure prophylaxis in preeclampsia without severe features is unclear, and the ACOG recommends individualizing the decision on the basis of risk-benefit ratio. Okay. Preeclampsia with non-severe features, the role of magnesium sulfate is still questionable. Okay, it should depend upon each patient. Whereas preeclampsia with severe features, yes, you need to give seizure prophylaxis in the form of magnesium sulfate. Okay, so important trial for this is your magpie trial. Okay, so this is seizure prophylaxis, not treatment. It is prophylaxis in preeclamptic patients. So magnesium sulfate halves the risk of eclampsia and probably reduces the risk of maternal death. Okay, if you use as a prophylaxis. There is no substantive harmful effects for mother and baby for short-term use. If you're using for short-term, yes, you can use magnesium sulfate for prophylaxis. Okay, this is the magpie trial for prophylaxis. Just remember it. Then comes your eclampsia. So if any patient has an eclampsia, so for the first important thing is your ABC. Okay, airway, breathing, circulation. Then calm the environment. Give magnesium sulfate. Okay, delivery if the gestational age is above viability in the given clinical care setting. Suppose if the patient has not reached the viability, expectant monitoring plus rigorous monitoring. And for refractive seizures, even after magnesium, the other drugs that can be used are phenytoin. Phenytoin is the most preferred one, and usually patient should be managed in ICU and consider the neuromonitoring. Okay. Now, what is the role of magnesium sulfate in eclampsia? Okay, so preeclampsia done, now it is eclampsia. So this is the treatment of choice for seizure prophylaxis, magnesium sulfate. So ACOG recommended dosing, we will see it. So what is the dosing? So loading dose is given as 4 to 6 gram administered in an infusion pump over 20 to 30 minutes, followed by maintenance doses 1 to 2 gram per hour as a continuous infusion. Continue till 24 hours postpartum. Please remember the doses. Okay, so everyone, when we are asking in the practicals, most of them are getting confused. Okay, so please mention the range. Okay, so 4 to 6 gram loading doses over 20 to 30 minutes, followed by 1 to 2 gram per hour, usually given for 24 hours. Okay, that is the dose of magnesium sulfate. If there are recurrent seizures, then additional dose of 2 to 4 gram can be infused over 5 minutes. Okay, so you can give little fast. When you give after the first dose, the second bolus dose can be given over 5 minutes. Okay, you have even the IM options. Okay, your regimes, so many regimes are there. Pritchard. Okay, so buspan regime. So IM option 10 gram initially as a loading dose, that is 5 gram IM in each buttock, followed by 5 gram every 4 hours. Okay. Um, so as I told, delivery, continue infusion 24 hours postpartum, post-vaginal delivery. And if it is a cesarean delivery, begin infusion before surgery and continue 24 hours postpartum. Discontinuing prior to operative vaginal birth or cesarean section to avoid uterine atony or anesthetic drug interactions is not recommended. So please remember this. So as an anesthesiologist, we are all worried, right? Because it causes uterine atony, or it causes a lot of muscle relaxation, additional muscle relaxation. If you give magnesium sulfate with anesthetic drugs, that is not there now. So do not discontinue magnesium sulfate. Okay. So coming to the mechanism of action of magnesium. So how does it prevent seizures? Okay. So seizures usually occur because of the excitotoxic neurotransmitters like our glutamate. Okay. So this glutamate usually it activates the NMDA receptors, which leads to massive depolarization of neuronal network and the bursts of action potential. So our magnesium may act to increase the seizure threshold by inhibiting these NMDA receptors, thereby limiting the effect of glutamate. Okay. So indirectly it is acting on glutamate by inhibiting the NMDA receptors. Okay. So that is a mechanism of action of magnesium sulfate. Now, when you're giving magnesium, we need to monitor for the toxicity of the magnesium, right? So how do you monitor or how do you prevent the toxicity? So first is any patient with magnesium sulfate infusion, please place a Foley's catheter and try to measure hourly urine output. Okay. Then confirm the normal serum creatinine. So measure the serum creatinine. Then you have to check your two important things. One is your deep tendon reflexes and next is your respiratory rate. Okay. So pre-administration respiratory rate should be at least 16 per minute. Your patellar reflexes should be present and urine output should be at least 30 ml per hour over 4 hours. If you meet these criteria, then you can safely start your magnesium sulfate infusion. Okay, so most of the patients, pre-eclamptic patients who have AKI, their urine output will be less. So in such cases, try to avoid magnesium sulfate. So see for a prerequisites. If those are met, then start your infusion and you need to monitor your urine output, your serum creatinine, your patellar reflexes and the respiratory rate. Okay. And then comes the important monitoring your serum magnesium levels. So now the guidelines are telling that serum magnesium levels are not routinely required. You only monitor the levels in the setting of renal dysfunction and or absence of patellar reflexes. Okay. And try to maintain the serum concentration between, remember one thing, okay, don't get confused. Either remember in mg per dl or milli equivalents per liter. Okay. So in mg per dl, it is 5 to 9. In milli equivalent, it is 4 to 7. Okay, so this is very, very important. You need to remember one value, which is mostly commonly practiced in your lab. You can remember that. Okay. Now, the predictive symptoms of magnesium sulfate toxicity. So, if the levels are more than 9 mg per dl, okay, then there is a loss of deep tendon reflexes, more than 12 respiratory depressions, more than 30 cardiac arrest. Okay. So what is the, if you find there is a magnesium toxicity, stop the drug and give your calcium gluconate. Okay, so until respiration begins to counteract the effect of magnesium sulfate, you can give your calcium gluconate. Okay. So in short, so how to manage any patient of preeclampsia. So hypertension pre-pregnancy, you treat with any antihypertensives that are available, avoid ACE inhibitors. Okay. And try to screen the patient. This is pre-pregnancy and the patient is planning for a pregnancy, then you need to treat this patient and avoid your ACE inhibitors, ARBs and your atenolol. Then hypertension early pregnancy, treat with or start with aspirin. Pre-eclampsia identified at less than 30 weeks, 37 weeks of gestation, treat the hypertension and then see and then see whether the patient has severe symptoms, non-severe symptoms. If the patient has severe symptoms, give even the magnesium and then decide upon the viability of, if you're planning for emergency um, delivery, if the patient has any other complication, do the delivery, or you're planning it in a day or two, then give the steroids for fetal lung maturation. Preeclampsia identified more than 30 weeks of gestation, treat for hypertension, and consider inductions once reached more than 37 weeks of gestation. Postpartum care is also very, very important because the patient might have the episodes of seizures for even around 12 weeks also, 6 to 12 weeks. So you need to have a proper postpartum care. Okay. So the in short is about the management of hypertension in pregnancy. What should be the what should be the BP control? What are the drugs that has to be used? What is the seizure prophylaxis? Okay, so this in short is your one slide or two slides which will you can write in your exam if possible. Okay, thank you. I think if Darshan is
Hi,
fine
ma'am.
to take.
Yeah. Can
Okay,
you
okay.
hear, ma'am? Can you hear
Yeah,
me?
yeah, I'm able to hear
Yeah.
Darshan now.
Yeah. Thank you, ma'am. Thank you for pitching in, and
It's
sorry,
okay.
guys, for the technical glitch. I hope it's done going to repeat itself, but I'm trying to avoid it as much as possible.
Okay.
I've tried to keep checks and balances right now. Is my slide visible, ma'am?
Stop sharing, Darshan. Now you share once.
Okay. Invisible, ma'am?
Yeah, Darshan.
Okay. Is it visible, the full screen?
Yeah, yeah, full screen is visible.
Okay, great.
Yeah.
Okay. So, thank you, ma'am. So going ahead with the topics, I'm really sorry for the glitch which happened half an hour ago. So I'd actually started off with the management of burns, and I told you these are the probable questions that would be asked. For guys who have just joined in, I had finished a couple of slides on definition and etiology and classification. Okay, so burns, the definition is just a coagulative destruction of the skin and its structure, either by thermal, chemical, or electrical, or a mechanical type of energy. Major burn and minor burn. This is how we broadly classify it. It's usually based on the body surface area which is involved, and more than 25% of the total body surface area involved will be categorized as a major burn in patients aged more than 16 years. Again, there are a lot of other issues, whether it is a partial thickness burn or a full thickness burn. That is what is going to help you understand. I'll discuss with you in detail once we see that, okay, in a next couple of slides. So classification is usually based on depth, etiology, percentage of body surface area affected, and combination, that is the degree of burn. Okay. So usually, why is it important? It is usually to help us understand and make a treatment strategy. That is one of the reasons why we have to know the classification. So type of burns based on the etiology, it is fired into electrical, thermal, chemical, and frictional type of burns. Again, they are subclassified into high voltage and low voltage and electrical, thermal into contact flame and scalds, chemical into acid and alkali. Okay. So this is something that you guys have to write when they ask about categorization of burns based on etiology. Coming to pathophysiology, burns is nothing but a complex traumatic event which involves tissue destruction caused by various factors like heat, radiation, chemicals, or electricity. Usually, this sets in a dysregulated inflammatory response, okay, that can be initially local and then it can become a systemic response. And then it starts off as a hypometabolic state and ends up being a hypermetabolic state. Okay. Again, this injury causes an overwhelming flush of a lot of cytokines. Okay. So this is nothing but inflammatory markers which gets delivered into the circulatory system, and that causes oxidative stress and a lot of metabolic changes, and because of which usually it ends up in multi-organ failure. Okay, so when that happen, usually in the initial stage of shock, we can categorize it based on 48 hours and more than 48 hours. Okay, the first 24 to 48 hours is the crucial phase of shock. That part of shock also would be associated with burns would be associated with burns shock. I'm sorry. Okay, so the first 24 to 48 hours of burns usually is of burn shock, that is also called as ebb phase. And the second half, usually more than 48 hours, it will be into a flow phase of burns. Okay. So in burns shock, that is the ebb phase, less than 48 hours, as a compensatory mechanism, there will be a vasoconstricted state, there'll be increase in systemic vascular resistance. And because of an inflammatory response, be it local or systemic, there will be some amount of capillary leak which happens. And because of this capillary leak, there will be loss of intravascular fluid. Okay, so they'll end up in something like a hypovolemic shock state. Along with this, because there is capillary leak, there will be some amount of edema which happens. And because of hypovolemia, edema, both together, they can lead to organ failure because of impaired perfusion. Okay, so this is the initial response: increased systemic vascular resistance and the hyperinflammatory state in the ebb phase. Ebb phase is usually called as hypometabolic. Then the flow phase is called as hypermetabolic. Okay, the word hypometabolic can also be interpreted as hyperdynamic. Okay, see here, the cardiac output is low. Okay, that is because of low volume state, but there will be compensatory tachycardia, etc. Okay, so that can be a type of a hyperdynamic phase. Okay, but remember, you can categorize burns into early, late. Early, that is your ebb phase or the burn shock phase. Late is hypermetabolic phase. In hypermetabolic phase, it will already be towards a transition from injury to recovery. Okay, so because there is a shift from injury to recovery with your resuscitative efforts which has happened, there will be increased oxygen consumption. Okay, protein wasting because of metabolic changes which would be happening for the recovery stage of a burns tissue. Okay, so this is what usually happens, and then there will be return of normalcy if the burns is not very severe. Okay, that is your SVR would be reduced, the cardiac output would be starting to be little supranormal or coming towards normalcy. Coming to local injury, I was discussing earlier. So usually any burns, okay, the local tissue can be categorized as zone of coagulation, that is the central area which has the irreversible tissue. Okay, this damage is permanent. We cannot do anything about it. So what we focus in our resuscitative efforts is the zone of stasis and zone of hyperemia. So this is where we are focusing so that this can be maintained and tissue loss would be minimized. Okay, so remember, zone of coagulation is the central area. Zone of stasis is the area around the zone of coagulation, and the outermost layer is the zone of hyperemia. Okay. So coming to burn shock per se, if they ask you what is burn shock, I told you earlier, you can categorize your burns pathophysiology into early or late. So usually burn shock is a type of a hypovolemic shock. Okay. So it usually is happening because of distributive derangements of fluids from intravascular compartment into the interstitium. That is because of capillary leak. Okay, so because there will be capillary leak and shift of fluid from intravascular to interstitial space, there will be profound tissue edema and hyperperfusion. This, along with the SIRS, which is already present, leads to an impaired cardiac function also. Okay, so I told you earlier there will be depressed cardiac activity, that is in the ebb phase, right? So all of this causes burn shock. Along with this, sometimes if prompt fluid management or resuscitation is not done to restore the intravascular volume, the patient might end up with the end organ perfusion issues. Okay, so these encompasses the burn shock. So if someone asks you what is burn shock, you can write it as a hypovolemic shock followed by a distributive picture, which happens because of capillary leak syndrome in earlier phases of burns. Okay, it is usually due to shift of fluid from intravascular compartment to interstitial compartment, resulting in tissue edema and hypoperfusion. Along with this, presence of SIRS, oxidative stress, and impaired cardiac function leads poor end organ perfusion, leading to shock-like states. Okay, so this is just about burns shock. Okay. So coming to immune dysfunction, I told you earlier, right? It is actually a double-edged sword, and initially it will help you. There will always be two types of inflammatory markers: your pro-inflammatory and your anti-inflammatory. Correct. So both are necessary for tissue recovery. But in burns, okay, what happens is there will be some amount of dysregulation. So there might be a lot of pro-inflammatory markers in the initial phase, which can cause damage, like what I was mentioning earlier, that is your burn shock. Okay. But then again, if your resuscitative effects are okay and you have taken out the inciting factor or the cause of burn, like be it thermal, chemical, etc., probably you can reduce the inflammation, and then we can switch over from injury to healing phase. Okay. So usually where do we see this? When usually there are major burns, inhalational injuries. Okay. So usually major burns are the picture where you will see an increased amount of immune dysregulation. So this is also a part of your pathophysiology of burns. Okay. So till now we discussed about pathophysiology. We spoke about what is burn shock, what are the phases of burn shock, what are the issues with immune dysregulation. Okay. And then we also looked at the etiology. Till now, if you are with me, then the next two parts of it would be healing. So healing usually starts with hemostasis, then recruitment of all your cellular networks, that is your neutrophils, macrophages, etc., to initiate the healing phase. Okay. Usually, this is also a part of the inflammatory phase of healing. Okay. Then we have something called as proliferating phase, wherein angiogenesis would happen, and lastly, we'll have remodeling. So these are the phases of healing which you should see. Mostly, what will happen is this will not be as categorically differentiated as it is in the slide. Okay, they will be having, or they'll